This conference will now be recorded.
Okay, so continuing from the last time where we finished off with the anatomy of the inguinal region, we had talked about both the uh, open and the laparoscopic anatomy of the inguinal region pertinent to the understanding of inguinal hernias and their subsequent repair. Now we'll proceed with the clinical aspects and starting with the embryology of the inguinal canal, which is an important part. So basically, what we're looking at is that in patients with pediatric inguinal hernias, there is a risk of embryological development rather than an acquired weakness, as compared to the adults where we say that it's an acquired weakness of the posterior wall. So here in pediatric inguinal hernias, we're looking at an embryological defect in development. So what is this defect in development? So it's related to the descent of the gonads. If you look at the descent of the gonads, a rough chronological uh, testicular descent, if you look at the chronology of testicular descent, roughly you can say at 6 months you find the testis which is up to the deep inguinal ring. Subsequently, seventh month in the inguinal canal, eighth month at the SIR, and by the third gestational week, in majority of fetus, the testis will have descended into the scrotum. Now, this descent of testis in the scrotum is preceded by the gubernaculum and accompanied by the peritoneal protrusion, which we call the processus vaginalis. Now, if you look at the process vaginalis, a few words of process vaginalis because it's important to understand why patients get congenital hernias. So, if you look at the process vaginalis, it normally closes about say 36 to 40th week, and the closure starts from the distal, from the deep inguinal ring distally. That means it doesn't close from the distal most part going proximally. Instead, it closes the DIR, and from there it proceeds in retrograde fashion and goes up to the tunica vaginalis, right, which is basically the part which is there in the testis. Now, 40% of these patients may have a closure up to the first month of life, and 20% additionally may close by the end of 2 years. But if you look at the overall picture, 20% of male children, you have a patent process vaginalis even at 2 years of age. If you look at the side, the left closes earlier than the right, and that is probably one of the reasons why right indirect guinal hernias are much more common than the left indirect guinal hernias, more than 60% of cases. Unilateral congenital hernia, 12% had contralateral patent process vaginalis. That means if you have congenital hernia on one side, it's not that the other side process vaginalis are already closed down. No, it's not that. 12% of patient may be having a contralateral patent process vaginalis, which may not have manifested as a critical hernia. And what is also true is that not all patent processes would proceed to inguinal hernia. You may have a patent process vaginalis. It's not necessary that you would be having a inguinal hernia. If you look at the 10 years follow-up of a patient who has got a process vaginalis, you'll find that 12% of these patent processes developed hernia. Only 12%. But the rate is almost 4 times greater than in the adults with closed process vaginalis. But it doesn't mean that 100% of patent processes would develop into hernia. So that is one of the reasons why it said that prophylactic contralateral repair is not advisable. Another reason why it's not advisable is that the complications of hernia repair, among them the more important being the chronic pain after surgery, even as high as 10-20% of patients developing chronic hernia pain. So these are some of the reasons why a prophylactic contralateral repair is now no longer advisable. Now, the normal immunological, if you look at the why does it close down? Why does the process vaginalis close down? Now, you'll find that there are myoepithelial cells, they are present in the process vaginalis, and they help in the testicular descent by propelling the testis into the scrotum. That's pushing the testis into the scrotum. At the same time, over a period of time, then these cells they would undergo apoptosis and convert themselves into fibrous tissue. So the muscle fiber will disappear, then the myopithelial cells they disappear, and they're replaced by fibrous tissue, thus facilitating the closure of the process vaginalis, right? And if you look at the distal most part of the process vaginalis, which we know as the tunica vaginalis, which is enclosing the testis, you'll find that there are absolutely no myoepithelial cells out there. Now, this is the normal embryological development, but there has to be something abnormal. So, what is the aberration in the embryology which leads to the genesis of a patency or the process vaginalis even after birth? Now, these smooth muscle cells probably may be persisting for a long period of time, leading to a local thickening around the internal ring. And if there's thickening along the or around the internal ring, it does not allow the processes to close down, right? So in lateral hernias or what are known as inguinal hernias, because of insufficient apoptosis, as indicated by documented absence of apoptotic nuclei in these smooth muscle cells, you find that they are not there. So these myopathiales have not disappeared and they have persisted, leading to thickening. Now, this failure of disappearance or failure of apoptosis could be related to a number of reasons. We'll just enumerate some of the important ones. One, the sympathetic nervous system enhances the smooth muscle growth. So probably there is something which is stimulating the sympathetic nervous system. It could also be androgen mediated because androgens indirectly regulate the descent of the testes by acting on the genitofemoral nerve, and it's probably through the mediated by the calcitonin gene-related peptide or CGRP, which normally transforms these epithelial cells into mesenchymal fibroblasts. So, in addition to propelling the testis, they are also leading to apoptosis of the epithelial cell. Now, these mesenchymal fibroblasts, they also secrete a hepatocyte growth factor, which is also probably helpful in converting more myopithelial cells into fibroblasts. Transforming growth factor beta 1 is also being implicated. So there are some of the cytokines or hormones which are important in the conversion of the myopithelial cells into fibrous tissue, ultimately leading to the obliteration of the process of analysis. So if you look at the cause of inguinal hernia, the first congenital we already talked about in the last 2 or 3 slides, that the process of analysis has probably is because of the non obliteration process of analysis. There could be other reasons to it. Number one, anatomical, and these anatomical relate to the weak spots, potential weak spots. And the most important potential weak spot in the region of the inguinal region is the posterior wall of the inguinal canal. The Because the whole of the Fluchard's orifice that we're talking about, the myopectoral orifice, is an area which is a weak area responsible for the hernia. So that is an important reason, the anatomical potentially weak spot, which is further augmented by the standing posture. Then there could be genetic reasons, which we have discussed when we were talking about the common principles of inguinal hernia. Common principles of hernia. There also we had referred to the inguinal hernias. So we're looking at hereditary with complex multifactorial inheritance pattern in inguinal hernia, and there has been recent identification of almost 4 susceptible loci which are related directly or indirectly to the genesis of inguinal hernias, right? And they are indirectly by connective tissue hemostasis. They are indirectly related to the genesis of inguinal hernia, and that's why we find that inguinal hernia is the more common collagen disorders. We already referred to the last time the Marfan syndrome, the Ehlers-Danlos syndrome, osteogenesis imperfecta, congenital heart disease, aortic aneurysm, and so on and so forth. So basically, what we're looking at is a decrease in the collagen 1 is to 3 ratio. That basically means that less of collagen 1, more of collagen 3. In addition to this, there's a reduced turnover of interstitial collagen type 3 and 5 and increased turnover of the basement membrane collagen type 4 in these patients who have got inguinal hernia, right? So this is all identifiable in patient inguinal hernia. Calcitonin gene-related peptide, hepatocyte growth factor, we already talked about, were responsible for the patency of the process. So we look at the causes among the genetic and familial causes. You identify that almost 10%, more than 10%, to be more exact, 11.5% of inguinal hernias may be having a positive family history. More so if the person affected is a female child, and more so if the sibling sister is affected. See that the highest risk of congenital hernia is seen in a sibling sister, where the relative risk is almost 7.8 times, right? Now, in the if the brother is affected, the risk is almost 5 to 6 times. Trauma is again a very important reason for genesis of inguinal hernias, and among the traumas, abdominal wall trauma, or it could be a surgical trauma, which we have referred to time and again, post appendectomy, post ureterolithotomy in the region of the endosubialic spine. If you give an incision, you're probably damaging ilioinguinal nerve and the iliohypogastric nerve. To be more exact, the iliohypogastric nerve is more important as far as the genesis of the post-operative hernias is concerned. So either on the right side or the left side, appendix on the right side, of course, ureterolithotomy right-sided, ureterolithotomy left-sided are all reasons for inguinal hernia. The other reasons for inguinal hernia could be pregnancy-related, Progesterone, we all know, induces the laxity of the ligaments. Elderly, the age group related to collagen degeneration and malganese bulges can be found in older age group. The lifestyle could be a major factor in inguinal hernias. So any condition which will lead to increase in the intraabdominal pressure could be responsible for the formation of inguinal hernias. So the reasons where you have an increase in intraabdominal hernias could be marked obesity, although a Swedish report has since then said that obesity is probably not a common cause for inguinal hernias. Weightlifters, professional weightlifters, not susceptible to direct inguinal hernias, but coughing, straining with defecation or urination, ascites, peritoneal dialysis, ventricular shunts, and chronic obstructive airway disease are all important causes which could lead to a genesis, but more importantly, propagation of a inguinal hernia. And that's why a history related to all these factors is very important whenever you're taking a history of inguinal hernia. Smokers are also increasingly susceptible, but what is now being understood is probably it is a cause for increased risk of recurrence rather than initial development of inguinal hernia. So it's uncertain whether the initial development of inguinal hernia is more common in smokers, but yes, recurrence is more common and has to do with collagen degradation, and there's increased serum elastase and decreased alpha-1 antitrypsin level in smokers. So the congenital theory of so when we look at inguinal hernia, we could be talking about two things. An inguinal hernia is congenital, inguinal hernia is acquired, or it could be a mixture of both. Now, the congenital theory of genital inguinal hernia says that all inguinal hernias are congenital in origin. They may be manifesting at any further point of time in the age group of the patient. So it doesn't necessarily mean that if the patient has got a congenital defect, he's going to manifest with a congenital hernia right the time after birth, or 1 year, 2 years, or 5 years, 6 years after birth. He could be manifesting even in adults. That is one theory. The other theory says that some of them are congenital, some of them are acquired. But what is the congenital theory of genesis? So, are both direct and indirect hernias or lateral medial hernias congenital in origin? Could be. Indirect, we all know it could be patent process vaginalis, easily explainable. But what about a direct inguinal hernia? How do you explain a direct inguinal hernia on the basis of congenital cause? So here we are looking at number one, a potentially weak spot with the Fluchard's orifice. Yes, we know that. But what is probably more important is that remember last time we were talking about the anatomy of the inguinal region. We talked about transalis fascia, and we talked about the inguinal region. The transalis fascia has got important analogs or thickening. Among them, the most important is the high arch fibers of transalis facial arch and the iliopubic tract. So, in a patient who is increased susceptible, if you look at a congenital cause, we'll find that the fibers of the transalis facial arch are high arch fibers, right? So, during the contraction of the abdominal wall, when these arch fibers straighten up, they should be approximating to the iliopubic tract, which they are not, right? So, this arching leads to a gap. Now, let's see to explain this more. These are the arch fibers. Let's examine this area. This is a transalis fascia. Rest of the layers have been removed, and these are fibers. So when there is a contraction of abdominal wall, these fibers straighten up. See, they have straightened up, and they'll be approximating the iliopubic tract. That's the iliopubic tract. So closes or reinforces the posterior wall. But if the same fibers are high arch, see the high arch, and when they contract, they are not able to approximate with the iliopubic tract. IPT is the iliopubic tract. They are not able to approximate. So that means it leaves a gap in the posterior wall. So the high arching of these fibers, and of course a congenital genetic defect in the collagen disorder or transalis fascia are two congenital causes which can explain the genesis of a direct viral hernia. Coming to definitions and clinical presentation, I think we talked about this last time. A bubnocele, funicular, and complete are the clinical types of any hernia. Bubnocele, the hernia is still inside the inguinal canal. A funicular is come up to the neck of the scrotum, and complete or scrotal when descended right up to the scrotum or to the base of the scrotum. The clinical presentation, the most common to start with, is always reducible. With the passage of time, becomes irreducible or incarcerated, becomes obstructed. There is a luminal compromise, strangulated, vascular compromise, and infarcted or frank gangrene subsequent to a strangulation. This we have referred to last time. Not going to go into further detail at this point of time. But how do you examine a patient inguinal hernia? What is important is inspection. And on inspection, a visible swelling per se or a visible swelling appearing on asking the patient to cough. And along with the visible swelling, you may also be able to see a Malgagne's bulge, which are areas of weakening in the lower abdominal wall, which, when the patient coughs, they are protruding out. Not a definite sac, but areas of protrusions. On palpating, the first thing you need to know is whether you're talking about a scrotal swelling or inguinal scrotal swelling, because the hernia has to be inguinal scrotal. If it is a purely scrotal swelling, it is not probably a hernia. The cuff impulse has to be looked at, and reducibility of contents have to be ensured. Apart from that, the most important test is the deep ring occlusion test, where after reduction of the hernia, you identify the DIR at 1.25 centimeters over the mid-inguinal point, press your thumb on it, ask the patient to cough, make the patient stand up. The hernia will not appear if it is a lateral or indirect inguinal hernia. The moment you remove your thumb, this hernia descends into the inguinal canal. The SIR invagination test is no longer done. It's very, very painful to the patient, doesn't give you any added information. So forget about the superficial inguinal ring invagination test, no longer a part of the examination of inguinal hernia. But the three finger Zeeman test is an important test. I'll show you in the next slide how we do it. Then once you have looked at the hernia, you should examine the contralateral side for a presence of a contralateral hernia. You should examine both the testis at the same time. And of course, remember, if you've got a diaphragmal hernia, it is rare in females, most common in males, wide neck. So the complications are very rare and usually limited up to the neck of the scrotum. This is how you do a Siemens test. This is the invagination finger test. Why the cross? Because no longer advisable. So forget this test. But this is an important test. You've got the ring finger. You got the index finger, the middle finger, and the ring finger. Femoral, direct, and indirect. So once you have reduced the hernia, you put the fingers on the appropriate spots of identification. You know the DIR, you know the superficial inguinal ring, and here you're looking at the femoral ring. So you're basically putting your fingers on this, ask the patient to stand up and ask the patient to cough. The first thing you would be feeling the impulse on any of these fingers, and then remove fingers one by one to see for the appearance of the hernia. And after the removal of a finger, if you find a bulge appearing, then that confirms that particular hernia. So you're looking at a direct, or indirect, or a femoral hernia. Now, one more thing of the Siemens test is that even despite these three fingers, and you ask the patient to cough and you find a visible swelling, then it is what is known as external supravesical hernia, right? Now, coming to the differential diagnosis, if it is a hernia, could it be something else? Yes, it could be a number of other things. You're looking at a vaginal hydrocele. You're looking, but more important, looking at a inguinal scrotal encysted hydrocele, or a encysted inguinal hydrocele, or a encysted abdominal scrotal hydrocele. That means there's a large sac which has gone from the scrotum into the inguinal region and gone retroperitoneally. A very, very large sac. Apart from that, you can be looking at a spermatocele, a varicocele, lymphangiocele, a femoral hernia. You could be looking at a maldescent testis. MDT is maldescent testis with inguinal testis, and a lipoma of the cord, which are some of the important differential diagnoses to be entertained when looking at inguinal hernia. Now, the investigation is usually not required. It's a clinical diagnosis, but it could be indicated when you have a doubtful diagnosis, as in a very small bubonocele, for ruling out other causes of inguinal and pelvic girdle pain are the two important reasons why you may be requiring investigating a patient inguinal hernia. One, doubtful diagnosis, and number two, looking at a possible other cause or other reason for inguinal pain, not necessarily because of an obvious inguinal hernia. So if you got an inguinal hernia and pain in the inguinal region, please do not take for granted that the inguinal hernia is causing that pain. You have to look for other causes, especially more important in the adult age group and heavy manual workers, sportsmen. That means 20 to 40 years of age group, and for reasons why you may be having this kind of problem in these patients. So what are the investigations you're looking at? You're looking at contrast peritoneography, where you inject a dye into the peritoneal cavity, and then with Valsalva maneuver, you take a film and look for a protrusion of the peritoneum through the DIR. Or you could be doing a CT scan, MRI, especially in those cases where you're looking for an alternate cause for the pelvic girdle pain. Or you could be doing a high resolution ultrasound scan with Valsalva, which just is investigation which mimics a peritoneography Here, instead of the dye being injected, you're just looking at the protrusion on a high resolution ultrasonogram. A laparoscopy for the still doubtful hernias, especially for the contralateral hernias that may be seen in 20% of cases. So, laparoscopy may be a good adjunct to a patient having a congenital hernia. And then, of course, diagnosing contralateral hernia. So the classification while hernias, does is it really required? It helps in planning treatment, and the most common is the NIHS classification, where you have type 1, 2, 3, and type 4, which is a recurrent hernia. The types are all written out here. I'm not going to repeat them, but just remember that type 1 and 2 are indirect, and type 3 has a direct, indirect, and femoral hernia, A, B, and C, and type 4. Gilbert's classification, and there is a score of other classification, at least five, six more classifications. But among all these classifications, one of the most pragmatic, which we now follow, is what is known as the European Hernia Classification, or EHS, European Hernia System. You're basically looking at what this was first came out in 2007. So you're looking at the PNR, that is primary and recurrent. One, two, three basically deals with the finger. So one finger dilatation of the DIR. So you're looking at the dilatation of the DIR. One finger, and one finger is less than 1.5 centimeters. So you're looking at one finger, two, three, and you're looking at the lateral, medial, and femoral. Lateral is indirect, medial is direct, and F is femoral. So one of the method of looking at a right side wall hernia could be a right, P is primary, L is lateral, and 2 is two finger dilatation of the DIR. So that's how you would label that hernia on examination, right, PL2. So this is one of the methods. Now you would obviously say that how are you going to measure it in a laparoscopy? Now what is very important is that if you look at the jaws of a laparoscopic instrument, when you open the jaws of the laparoscopic instrument, it is basically looking at a dimension of 1.5 centimeter. So that is the length of jaws of a pair of a most laparoscopic graspers. So that gives you an approximate idea whether they're looking at one finger, two finger, three finger. So what we are trying to say is that this is a classification which is pertinent both to open and laparoscopic classification. The treatment principles are simple. One, wait and watch, which came up in a very big way about 10 years back, but now has fallen to disrepute. Why? Because during the study where they did a wait and watch policy, they found a number of complications. They abandoned the study. But there's a very small group of patients where wait and watch policy uh, could be tried out. Number one, very early in the development of a hernia, asymptomatic hernia patients, direct hernia patients, because the complication direct hernia is highly uncommon. Elderly patients or patients who have got other comorbidities, wait and watch policies, including, of course, hesitant or reluctant patients, wait and watch policy may be tried. So, this is a very, very small group of patients where you could go in for wait and watch policy. But otherwise, all hernias should be treated surgically, either by open method or endoscopic method. And the principles are basically you have to manage the sac, then you have to the deep inguinal ring, and then you have to repair the posterior wall. Very, very simple. Three things to be done. One, do something for the sac. Number two, do something for the DIR or deep inguinal ring. And number three, repair the posterior wall. Now, only 20-30% of surgeons attempt laparoscopic approach. That is also true. It's now approaching towards 30%, but still, the majority of surgeons are still doing an open hernia repair. So we have to know what open hernia repair is all about. But fortunately, or I would say, I would like to put adjective it, whether it's fortunate or unfortunate, but more and more people are now trying, or more and more surgeons are now trying to do a laparoscopic hernia repair. Now, coming to the terminology, this we had discussed last time, the herniotomy, the ectomy, the RAFI, which is approximation, hernioplasty, which is bridging. I'm not going to go to the details of that again, but remember that both the RAFI and plasty. So you're looking at the management of sac, that is otomy and ectomy. You're looking at DIR management, the littles repair in the next slide. And managing the posterior wall can either be by bridging or you could be reinforcing with any of the natural tissues or biological or synthetic tissue. So, a combination of a management of the sac, DIR, with either RAFI or plasty is the total management of a patient while hernia. When you're doing the RAFI or plasty, it could either be anterior repair or it could be a posterior repair. That's the terminology that you may like to remember. Anterior repair, when you say anterior repair of a hernia, you're basically looking at a repair not only from the anterior surface, because even you're proceeding from the skin down back, it could still be a posterior repair. So the definition of anterior and posterior repair is different. What is the anterior repair of inguinal hernia? Anterior inguinal hernia is a repair which utilizes structures which at all times are lying anterior to the inguinal cord or anterior surface of the inguinal canal, right? Anterior to the cord, any part of the inguinal canal. Okay. If you look at a posterior repair, we talk about a layer which is lying truly posterior to the inguinal cord in the region of the inguinal canal. So we're looking at only one structure, and that is transalis fascia, which is truly, because even the transalis abdominis muscle, inguinal, the internal oblique muscle, remember in the lateral part, they lie anterior to the cord, and then they form arching fibers and go posterior to the cord. So if you're looking at a transalis fascia, repair, that is the true posterior repair, whether you do it by anterior, by do by open method, or you do it by the closed method, right? Now, the sac has to be dissected up to the neck. So, manager of the sac, what to do with the hernial sac? Dissect it up to the neck. Remember last time I told you about the anatomy? I said that the deep inguinal ring are two, the conventional, and number two is the deep inguinal ring or the secondary deep inguinal ring. So you have to go up to that part. And how to identify the neck of the sac? When you find the bulging of the extrapyramidal fat. So you have dissected the neck up to that part, and then subsequently that is the second layer of the transalis fascia. And subsequently you can do three things with the sac. One, if the sac is small, push the sac back into the preperitoneal area without ligation, just reduce it, and that would be easily mobilized and completely dissected. Other sacs can be managed with that small sac. Now, if you're tying a sac, the sac is parietal peritoneum. So, if you're tying a sac, you're looking at a parietal peritoneum being tied. It has got sensory innervation, so that would be one of the reasons for postoperative pain after inguinal hernia could be tying of the sac. So, deposit a small sac after dissection to the preperitoneal space. Method number one of managing a sac. Method number two, ligate the sac, excise the part distal to it as we do in a congenital inguinal hernia. The third is ligation of the sac and leave, transect the neck, ligate, transect the neck and leave the distal part behind. Why? Because the more you dissect, try to dissect the sac out, the more the bleeding and more the post-operative hematoma, seroma, and inflammation, which is basically a surgical inflammation or surgical edema. So leave the distal part in situ if you got a very large scrotal sac. So three things which can be done with the sac: push it back into the preperitoneal space, leaving it as such. Number two, ligate, excise, remove the distal part. Number three, ligate, excise, leave the distal part behind. Three methods. Now, once you've dealt with the sac, now what do? Deal with the DIR. And what do you do with the DIR or deep inguinal ring? You have to repair the DIR, especially in those cases where it is two or three finger dilated. So how do you repair the DIR? Remember, the obliquity of the inguinal canal has to be maintained. So the repair of the DIR should always be from medial to lateral. That basically means that the stitches should be applied from medial to lateral so that the cord is pushed more laterally. Obliquity of the cord is maintained. If you apply sutures from lateral to medial, pushing the cord more medially. So what you're looking at in all these patients in a little repair is that you repair the DIR, narrow it the medially, and the suture should be applied medially and the cord should be pushed laterally. It is an important essential component of only open repairs. You cannot do a little's repair in a laparoscopic. It has been tried, but there are chances that there could be a problem with that. But conventionally, a little's repair is a part and parcel of an open hernia repair. And that also for a lateral inguinal hernia repair, it is not a part and parcel of a medial or a direct inguinal hernia repair. And then comes the last part or the most important part, and that is reinforcing the posterior wall. And reinforcing the posterior wall, as we just now said, either anterior repair or posterior repair. In either case, it could be RAFI or it could be plastic. Now, among these, the most important and the time-tested method is what we know as the Bassinese or the modified Bassinese or the Shoulders method, which is the open anterior hernia RAFI. An open anterior herniorrhaphy, Bassinese, modified Bassinese shoulders. The hernioplasty, which is anterior hernioplasty, is the Lagenstein, which up to now is the gold standard of repairing inguinal hernia. Now, the posterior repair, which I just now said, is utilizing only transverse fascia. So you've got a Cooper's ligament repair. But if you're doing a posterior hernioplasty, posterior repair or hernioplasty, it could be all prepeitoral repairs in an open method. So that means all prepeitoral repairs are posterior hernioplasty. It can be done by open method, the Nihas, the Stopa, the Kugels, Ughari, anterior preperitoneal, or it could be a lap where you have a TEP, where you have a laparoscopic repair, where you're doing a TEP repair or a TAPP repair or extended TEP repair. So you're doing a preperitoneal repair, either case, whether it's a hernioplasty by open method or a hernioplasty by a closed method. You could do a laparoscopic repair or you could do an open repair. Okay. Now, coming to some of the figures that I wanted to show you, this is basically why did we say Bassery's repair? A time-tested repair, although not a very good anatomical repair. I'm not going to go to the details as far as what is anatomical repair is. Now, remember, whenever you're doing any kind of surgery, the basic dictum is, or the basic aim is, try to maintain the anatomy and physiology as near normal to possible, as normal as possible, right? Now, in a Bassery's repair, what are you doing? You're trying to drag, these are conjoint fibers, this is the iliopubic tract and the inguinal ligament. You're trying to apply sutures and approximating. Now, what are you doing? The arching fibers, are they supposed to be approximated permanently to the inguinal ligament? No, they are not. They're not. So you're disturbing the anatomy. So you're not really a complete anatomical repair, right? But nevertheless, Bassery's repair or modified Bassery's repair has stood the test of time. And when we say stood the test of time, we're looking at the recurrence rate. It gives very good recurrence rate. It is very easily assimilable by even the resident in learning. They can easily understand and do a Bassery's repair. Two very, very important criteria whenever we talk about any inguinal hernia repair. One, it can easily be carried out by the resident or the starter or the early surgeons. And number two, it should be giving acceptable results both when the novice surgeon is operating as well as when a very experienced surgeon is operating. The results should not be at great variance. So that is where Bassini has stood the test of time and is still being done. One of the most common methods of repair is still Bassini's repair. It's a triple layer approximation. What is the triple layer? You talk internal oblique, transabdominis, and transhalus fascia. Three layers to be approximated to the inguinal ligament. That is the Bassini's repair for you. Okay. Now, coming to the shoulders repair, which is considered to be the hallmark of a RAFI, a gold standard RAFI. If you ask about a gold standard RAFI, remember, gold standard of inguinal hernia plasty is basically what? The tensionless Lakenstein's repair. No two views about that still. But when you're talking about a gold standard RAFI, it is shoulders repair. Although I fail to understand why it is still called as the gold standard, it's a very, very difficult repair and the results are not reproducible by all surgeons. Even the results which the shoulders clinic, shoulders repair comes from the shoulders clinic, which is a clinic in Canada. So basically, you're looking at a clinic where they do only this repair and they give very good results of less than 1% recurrence rate. Now, that result of less than 1% recurrence rate is not reproducible by surgeons at large. That basically means a surgeon who is doing this repair at any other point or who's doing it less commonly would be giving similar results. No, he doesn't. So that's why the results are not reproducible. That's why to me and to a lot of other surgeons doesn't appear to be very good repair. Although it is, and then of course a very, very cumbersome repair, technically difficult repair. Why? Look, you're doing a 4-layer inguinal hernia repair. 2 layers of double breasting of transhalus fascia, 2 layers of double breasting, first line suture, second line suture, both transhalus fascia. So you've dissected the transhalus fascia and done a double breasting of transhalus fascia. Next, what do you do? Next, you do a double breasting of the conjoint tendon. So you got 4 layers to it. Now, a very small area, trying to do a double breasting leads to a lot of damage to a number of structures. Initially, the shoulders repair was done with a stainless steel wire. Now it's done with synthetic monofilament. And then, of course, after that, external oblique approach is closed either singly or again a double breasted fashion. So it's a 4-layer repair, 2 layers of transhalus fascia double breasting, and 2 layers of conjoint tendon double breasting, which is done. That is the shoulders repair. You should know what shoulders repair is, but still considered to be a gold standard herniorrhaphy. Remember that. But the gold standard of repair is like a steel repair, where you put in a mesh in the posterior wall. This is the cord. There's a mesh in the posterior wall, and there's like a seals repair. And this like a seals repair is the gold standard as of now. Despite the fact, remember, it does not obey the Pascal's law. Now, what is the Pascal's law? Why does it obey that? As far as UGs are concerned, may not be of major concern to you. But then, what you're looking at in these patients is that whenever you're putting in a mesh, you're putting in a mesh on a circular fashion. The mesh should be such that when the pressure increases, the mesh should be more closely approximated. That means if you put this mesh in the preperitoneal space, it would obey the Pascal's law. But here, where you're putting the mesh, you're putting the mesh in the most superficial layer. So when the intra-abdominal pressure increases, this mesh is going to be pushed out. So that is not obeying the Pascal's law, right? Another method of doing a plasty. So these are basically plasties. Other method is what is known as plug and patch. See this plug we pushed in? So that is a plug. That is how it looks like. So deep in ring, the plug goes into the preperitoneal space. But the problem with these plug and patch repairs is that you're putting in a lot of foreign material inside. So now the understanding is that when you're doing any kind of repair, you should use less and less amount of foreign material. So plug and patch is no longer advisable. Then coming to true posterior raphes, I told you utilizing transalis fascia. Now see here, this is what the iliopectineal or the Cooper's ligament, right? So you're basically approximating transalis fascia to the iliopectineal ligament. So you're truly using a structure lying truly posterior to the inguinal cord in the region of the inguinal canal. That is the McVeigh's Cooper's ligament repair. And if you find the other thing which is important in all these raphes is that if you find that there is a tension when you're applying these sutures, there's a tension, then you should put a relaxing incision. This is a relaxing incision over the anterior rectus sheath, giving rise to what is known as relaxation of the posterior layer, and there the sutures hold much better. The tension over the posterior wall is relieved, and here you create a gap which can then be stitched. This is known as the Tanner's slide. So that is the McVeigh's repair with the Tanner's slide, the McVeigh's repair without a Tanner's slide. So you have looked at the anterior repair, you look at the posterior repairs, and you looked at the hernia repair, you look at the plasty. But coming to the posterior repair, which is the open repairs, so this was a posterior repair which was a hernia raphe. But what about plasties? Open plasties, you can be talking about putting in a mesh in a preperitoneal space. Now we all know TEP and the laparoscopic repairs, you put in the mesh in the preperitoneal space. We know that. But that's the laparoscopic, you're proceeding from the posterior to the anterior. But can you do the same thing from anterior to posterior? Yes. So in open repair also you can do a posterior plasty. So we are giving the Nihas repair, the Kugel's repair, the Ughari repair, and our repair, which is basically trans-inguinal to the deep inguinal ring. We go through the deep inguinal ring. So we have modified the anterior preperitoneal repair as a true posterior repair, which is known as the TIPS operation, right? And then, of course, the basis of all present-day lap repair, what is known as the rift stopa repair, where incision given either vertically or given transversely. Vertically, transversely, and you go to the preperitoneal space, and when you enter the preperitoneal space, you're going to push in the mesh in the preperitoneal space, right? That's the rift stopa repair, which forms the basis of all present-day laparoscopic repairs. So you are putting in a mesh in the space of Ritzius and Bogoros. Remember last time we talked about that. Okay. Now, coming to disadvantage of these repairs. So, what is the disadvantage? When you talk about basilism, I just now told you it's not a purely anatomical repair. The Lakenstein's repair does not adhere to the tenets of the Pascal's law, right? Now, trying to maintain or uh, bring the restoration of the anatomy towards normalcy should be the main aim. So Bassinese does not do that. Amount of mesh is a major variable, so plug and patch, and protein hernia system are no longer advisable. If there is tension at the raphe side, add a plantar slide. So these are basically some of the disadvantages of some of the repairs which are commonly done and considered to be gold standard. But they are not pure, they are not without criticism. There are critics with each of these repairs which show them as disadvantageous factors in the repair of these hernias, right? Now, you're looking for a recurrence rate of less than 1% in all repairs, whichever one you try to select, and chronic neuralgia of less than 10 to 12%. Now, when we say a repair of the inguinal hernia, what we are looking at is inguinal hernia surgeon is a surgeon who's not only versed with one method of hernia repair, he has to be well versed with all methods of hernia repair. Only then you can be called as a hernia surgeon. So you have to be for both a laparoscopic and you have to be familiar with the open repair. We're just showing figures for a TEP and a TAPP repair. TEP is totally extraperitoneal repair, and this transabdominal preperitoneal repair. So these are the ports. How you put it. This is the pubic tubercle. This is the caudal end. This is the cranial end. The head is here. So this umbilicus, the first port, and you got the two ports out here. This is how it looks like. I'm not going to go for the details. That's beyond your scope, but just remember that's how it looks like in a TAP repair. And if you look at the TAPP repair, then looking at a 10 millimeter umbilical port and two lateral ports, 5 millimeter ports, right? At the lateral border of the rectus abdominis muscle. So the difference, the essential difference between TP and TAPP is in a TP repair, at all times, this is the peritoneum. See, the blue is the peritoneum. So at all times, you're in the pre-peritoneal space. At all times, you're not gone into the peritoneum. But the same thing when you go into the abdomen and then cut the peritoneum and then enter the pre-peritoneal space, that is a TAPP repair. So that's the essential difference between a TEP and a TAPP repair. In one, the peritoneum is not to be breached. In the other, you have to go into the abdomen, breach the peritoneum, and then enter this area. The green area is the area which has to be approached, the here and here. So here it is a pre-peritoneal, here it is transperitoneal. The essential difference between a DEP and a TAPP repair. And then, of course, the latest entrant, and that is the extended TP repair, which is also known as the enhanced or extended TP repair. I'm not going to go into the details of that, that's beyond your scope, but just remember, it's probably slightly better than TP, still not proven. Why? It gives a flexible port setup. As in TP, I just not told you that you got a port setup out here. In TP, in XLTP, you can even put a port here also. So a very variable port application, a flexible port setup is one of the major advantages, and it gives a very large area for dissection, right? So this ETP method has also given a larger application of this procedure, not only for inguinal hernias, it also becomes a very good method for approaching ventral hernia. Beyond that, it's beyond your scope, right? Now, so the new international guidelines for hernia surge group, what you'll do with inguinal hernia, and what is recommended is the open mesh technique like in STEAM and the laparoscopic mesh technique TEP and TAPP are the recommended methods of tackling inguinal hernia. Now, generally accepted technique suitable for all inguinal hernias does not exist. You cannot say that this particular technique is good for all hernias. Remember that. That's very important. It has to be tailored on two very important things. Number one, the presentation of the patient, and number two, more important, the surgeon who's doing it. So, the repair to be selected is not universally same. It varies from patient to patient. It varies from surgeon to surgeon. Right now, as of today, a laparoscopic approach, which is either TEP or TAPP, is the first choice, provided the surgeon has got sufficient expertise. That's very important for primary unilateral inguinal hernias in men and women, and for bilateral cases, and for recurrent cases after open hernia repair. Now, the other recommendations, bilateral hernia, prefer a laparoscopic approach. Recurrent inguinal hernia after previous open, laparoscopic. Recurrent after laparoscopic, prefer open technique. Simple, right? Now, what about prophylactic operation? A prophylactic operation of the healthy other groin should not be performed. See this. Why I just now told you that the incidence of neuralgia is quite high, and you may be creating a major problem for repeated rather than benefiting the patient. You have a very large scrotal hernia. In fact, it's a very large hernia. Then you have to decide on the table or decide preoperatively an open hernia repair would be better or a laparoscopic hernia repair would be better. After previous pelvic or lower abdominal operations, probably because there were a lot of adhesions inside the abdomen, so probably an open operation like a seen may be better. Associated comorbidity, where the patient cannot be given a major anesthesia for a prolonged period of time, probably an open operation may be slightly better under local or regional anesthesia. Emergency surgery for inguinal hernia, that means a strangulated or obstructed. Obstructed, you can still do a laparoscopic repair. If you've got a strangulated, it has to be choice whether you want to go in for a mesh or a RAFI. Why? Because the moment you go in for a bowel transection or resection, contamination is present. So prefer a RAFI rather than putting in a plastic. Why? Because remember, mesh with infection is a major problem. So if you open the abdomen, sorry, if you open the bowel in a strangulated hernia, probably not putting in a would be a better option, right? Now, special presentation, I just now said, strangulated hernia operated within 6 hours of occurrence may prevent gangrene. 6 hours is the golden time period for strangulation. From the time strangulation occurs, within 6 hours, if you intervene, you probably be saving the bowel. If you intervene after 6 hours, you will not be saving the bowel. The bowel undergoes gangrene. Constriction ring is most commonly not the DIR, it is the neck of the sac. A very, very important fact. That's why I've written it in bold. You may require excision of the omentum or intestine in a strangulated hernia. Mesh is not a very good option, strangulated hernia. What about sliding hernia? Exclusively, special presentation sliding hernia exclusively in males more than 40 years. 80% left side where you find a sigmoid, right side 20%. No herniatomy to be done. Remember that, please, for God's sake, do not do herniatomy and sliding hernia. If you do herniatomy, sliding hernia, you're going to tie what? The sigmoid colon, or you're going to tie the ascending colon. And then you have had it because this patient is going to obstruction, perforation, and all kinds of major problems. So just do a dissection, push everything back in. Do not, because there is no sac. The sac on one side is formed by the bowel. I remember when we talked about sliding hernia last time. So remember that. Just remember that lecture. So in a sliding hernia, please do not do a herniatomy. In a Madel's hernia, the gangrenous loop may be in the peroneal cavity. Remember, this is a W-shaped hernia. So draw the bowel out so that you got only one entering and one exiting into the peroneal cavity. If you have two exiting and two entering, you have got a Madel's hernia. So remember that. You'll be leaving a gangrenous bowel inside the peroneal cavities. Please do not do that. Early complications are bleeding from the infraepigastric vessel, iliac vessels. You could be having a peritoneal tear, or there could be injury to the contents in the form of bowel injury or to the urinary bladder injury. Late complications, slightly late seroma formations, which often create a problem with laparoscopic repair, which can mimic a recurrence, and the patient is very much petrified that look, this is a swelling, I came for the swelling, I again have the swelling, your operation has failed. But all the time, it is not a true hernia, it is a seroma collection. Then you can have a surgical site infection. SSI is infection of the hernial wound. Long-term complications are the of major concern. You could have a recurrence, acceptable recurrence 1 to 2%. Anything more than that is not acceptable. But then there are recurrences. Overall recurrence have been mentioned as 10 to 15%. When you take together the learning surgeon, the resident, and then of course you're talking about the experienced surgeon. Chronic neuralgia, defined as pain occurring even after 3 months of surgery, is a major problem occurring in 10 to 12% of patients, and that is more common in open hernia repair, and that is where the laparoscopic hernia scores over the open repair. Right? So open versus lap. Remember the three critical areas of laparoscopic repair. Remember we talked about the circle of death. We talked about the triangle of doom, and we talked about the lateral triangle of pain. So these are the areas where you got a complication. Laparoscopic repair and open repair. We already talked about these complications, right? Sportsman's hernia slightly needs an addressing. Why? Because remember, I told you that when you have a 20 to 40 years age group of patient or a heavy manual worker or athlete, these are those group of patients where it should not be taken for granted that the hernia which is there evident is the cause for inguinal pain. If the patient comes to inguinal pain, you find a hernia in that age group, please do not go ahead and do a surgery without investigating the patient. Look for other causes. Look for girdle pain. So do a MRI, do a CT scan, whatever you want to do. Look for muscular pain, look for bony pain, look for ligament pain. Until you rule all of them out, please do not say that the pain is because of the hernia. Only then go and treat the hernia as such. So you have to treat the cause for the girdle pain in these patients. Just a few words of femoral hernia, which we'll be finishing the groin hernia. So looking at a femoral hernia, you need to understand two things which are very important. Number one, the femoral ring. And if you look at the femoral ring out here, see this is the femoral ring. Can you see the femoral ring? So medially you got the lacunar ligament. That's the lacunar ligament medially. Laterally, what do you have? You have basically the femoral vein out here. Anteriorly, what do you have? You have the iliopubic tract. Posterior, what do you have? You have the iliopectineal ligament or the Cooper's ligament, right? And this is the tissue separating it from the femoral vein. The canal is from here to here. So we look at the canal medially. You got the epidorsal abdominal insertion and transverse fascia, and posteriorly the Cooper's ligament and the fascia iliaca. This is the area from where you have the exit of the bowel loop, and this is the femoral hernia which is exiting. A very, very good picture. That's why I showed you. One very important thing in this picture to be noted is you see this artery out here, which is in the area of the lacunar ligament, the aberrant obturator artery. And that's the reason why the lacunar ligament should never be cut like this. When you're releasing an obstructed femoral hernia, please, please do not cut the lacunar ligament like this. Why? You may be cutting a aberrant obturator artery. And if you're doing it, you have had it, you'll not be able to control that artery. You'll have to go in, do a full laparotomy, and then try to identify the origin of the aberrant obturator artery. So we look at the sheath, it extending from the ring. There's a sheath from where ring to the saphenous opening. That's the whole sheath, right? So it is about 1.25 centimeter long and about 1.25 centimeters wide downwards. Contains what? Very important pad of fat, lymph node or cloacae, and lymphatic, and terminates at the saphenous opening. This is the pubic tubercle. So you're looking at 3.75 centimeters below and lateral pubic tubercle. Pubic tubercle, saphenous opening, 3.75 or 1.5 inches below and lateral to it, right? The metaphyseal femoral hernia, this is the most common, but you can have this is the most common, just like see the femoral vein lying medial to it. But you can have a prevascular lying anterior to the vessels, post-vascular or retrovascular lying posteriorly, and you can have a lateral femoral hernia. So the femoral hernia is usually medial to the vessels. You can have anterior to the vessels variation, posterior to the vessel, or you can have lateral to the and the different names available, right? The nares hernia, or you have got the lateral femoral hernia, the clockwise hernia. Then you can have a hernia which is escaping through the lacunar ligament. So if you look at this figure, instead of coming from here, it could be escaping from here, a defect in the lacunar ligament. So that is a variation of a femoral hernia. So there are some of the variations of the femoral hernia, the Logier's hernia, the Naras hernia, the Serafini hernia. So these are some of the names given to variations in the femoral hernia presentation. You can look at this when I upload this lecture. These are some of the variations of femoral hernia. I'm not going to go to the details of this. Coming to as a whole, if you look at the femoral hernia, 3% of all hernias are femoral hernias, more common in females. 20% of all in females, 5% in males. Females, why is it more common? Because they got a wider pelvis, they got a large femoral ring, wider femoral canal, especially more common in the old age group when you've got the dissolution of the fat. So low weight, old age, the buttressing of fat, and wide pelvis are those scenarios where you've got an increased incidence of femoral hernias. Said earlier, most common in the old age group, right? 40% of all femoral hernias present with strangulation, which means that as compared to inguinal hernia, the incidence of complications is very, very common in femoral hernia as compared to inguinal hernia, more common, right? Uh, the swelling is not very visible. It usually occurs the occult swelling. Why? Because it's lying underneath the fascia, or it could be very small swelling, which can easily be mistaken for a lymph node lying in that particular area. Early obstruction, early strangulation, difficult diagnosis, and then, of course, a CECT may be required in those cases where you're suspecting a strangulated femoral hernia, right? Now, coming to the differential diagnosis, very, very important. Why? Because femoral hernia start with a very small, just a button-like protrusion, and there it can be easily. And then, of course, then what happens as it grows up? It grows upwards. So it has to be differentiated from a direct inguinal hernia, a diagonal hernia, saphenavarex, enlarged femoral lymph node, lipoma, aneurysm, psoas abscess, distended psoas bursa, and of course, hematoma of the adductor longus rupture. So these are the differential diagnoses. What? How do you treat a femoral hernia? Either open method or laparoscopic method. Again, raphe If you're doing an open method, you should do a Cooper's ligament repair, the McVitie's repair. But the preferred is always the femoral approach. Can be done easily with a local anesthesia. Just give incision over the sac and then go in and repose the sac back inside and close the opening, the femoral ring, and that is the Lockwood. That's the preferred method. Or you can go through the inguinal area, what is known as Tyson's method, or you can do suprainguinal, the McVitie. But by and large, if you look at the femoral hernia, the preferred method as of now is a laparoscopic TAPP or TEP, which covers the femoral area along with the whole of the Fruchard orifice. If you've got emergency obstructive strangulate femoral hernia, which is the more common presentation, then the femoral ring has to be enlarged just by dilatation. Please do not cut the lacunar ligament. I told you why, because the aberrant obturator artery may be there, which is found almost 30% of cases at the edge of the ligament. See, 30%. In that case, you'll be cutting the artery and you have troublesome bleeding on your hands, right? The femoral ring can be dilated and be pushed inside. If not, then you have to go in for a full laparotomy, enlarge the ring, and drag the intestine back into the abdomen, right? And laparoscopically, cutting the lacunar ligament is much easier than cutting it by open because from open, you're doing a blind procedure, the artery is lying behind the lacunar ligament. If you're doing laparoscopically, you can see the artery is in front of you. So even if you want to cut the lacunar ligament to enlarge the opening, it can safely be done when you're doing a laparoscopic approach to it. The last is supravesical hernia, and there are two types. One is the external, the other is the internal. So looking at the area of the abdominal wall between the two medial umbilical ligaments. Medial, remember, part of the umbilical artery obliterated and divided with the median or the uricus into two parts, the right and the left. So the inferior boundary is by the peritoneal reflection over the bladder, and the weakness in supravesical fascia leads to genesis of external hernia, or it could be an internal hernia, right? So the internal hernias could be anterior, right and left, and posterior. I don't think you need to know that as UGs or PG may be required to know what an internal supravesical is. But just remember why is supravesical important. See, this is supravesical hernia. Can you see supravesical hernia? External supravesical hernia in the blue. So it can present medial. So this is a direct bile hernia. It can present it, or rather, it presents medial to it. So it can present through the anteabdominal wall. It can come out from here, medial under the Hasselbeck's triangle. It could be coming out through the femoral ring, or it could be coming through the obturator canal. So external supravesical hernia has got four sides from where it can be protruding through the anteabdominal wall. It's always misdiagnosed as a direct bile hernia. 99.9% supravesical hernia is diagnosed as a direct bile hernia. And it becomes more easy to identify a supravesical hernia by laparoscopic approach rather than by open approach, because in a laparoscopic approach, you got the defect in front of you, can identify whether the defect is lying medial to the pubic tubercle or lying lateral pubic tubercle, medial to it or lateral to it. So you can easily identify it, right? So more identifiable on a laparoscopic approach. The symptoms and treatment, presentation I told you as the inguinal hernia, complication as an intestinal obstruction, the diagnosis either laparoscopically or by a CT scan, right? I think that finishes the groin hernias for you. Next time we'll be talking about ventral hernias. If you've got any questions, you can always come back to me. Thank you for your time.